Assalamualaikum and good day everyone. Welcome back to the last topic of PhD 615, Pharmacology of Drug Affecting the Cardiovascular System. So in this week, the last week, we are going to cover the pharmacotherapeutic management of cardiovascular disease, particularly in hypertension as well as the chronic kidney disease. So here are the learning objectives for this week topic. I will divide this week lecture into two parts. The first part will be discussed on the hypertension, how you want to initiate the treatment based on the assessment that you find from the case study. And then you need to discuss on the mechanism of actions as well as the its therapeutic indications. And the second part will be discussed on the chronic kidney disease, especially on the identify the risk and early detection of the CKD patients so that you can prevent the progression towards to the end-stage renal failure by optimize the pharmacological therapy. So without further ado, let's discuss the first part of this lecture on the pharmacotherapeutic management of hypertension. So here is the case study that we will use as our basis for discussion throughout this lecture sessions. So by using this scenario as a model, we will hopefully be able to put into practice the knowledge that you have gained throughout this semester, particularly on the pharmacological of cardiovascular drugs. So Mr. HA is a 50-year-old accountant admitted 2 days ago to hospital following a breakout while watching football match with his sons. So past medical history indicates no medications and he is fit for his age and no existing any diagnosed medical conditions. During examination, he is slightly overweight, which will weigh about 81 kilograms. He is a smoker and his blood pressure is about 165 over 90 millimeter per mercury with heart rate of 90 beats per minute. So doctor diagnosed him as a hypertension. A person is considered to have hypertension if their systolic blood pressure is more than 140 millimeter per mercury or if diastolic blood pressure is more than 90 millimeter per mercury. So this hypertension can be further categorized into 4 stages. The first stage are known as stage 1, which is mild hypertension. Stage 2 is the moderate hypertension, and stage 3 is the severe hypertension. And another stage known as isolated systolic hypertension, where the patient having problem with his systolic blood pressure, which is more than 140 millimeter per mercury, when the diastolic reading, which is in the target, which is less than 90 millimeter per mercury. So this patients usually will restart any antihypertensive drug will be discussed further. Why this antihypertensive drug is important? Because we want to normalize the pressure on which is our target is less than 140 or 90 millimeter per mercury for the diastolic. But when the patient has any comorbidities such as diabetes, so we target more aggressively, which is less than 130 or less than 180 millimeter per mercury for the diastolic blood pressure. Aside from that, we want to prevent any adverse reactions or any side effects due to the antihypertensive drug, or we want to avoid any hypertension issue. So these pharmacological treatments are important for the patients because we want to prevent any further comorbidities such as stroke, retinopathy, or myocardial infarctions. Besides, we want to prevent end stage or end organ damage, especially in the heart as well as in the kidney. So back to our case study. So Mr. HA are not any medications or any medical conditions. So his blood pressure is 165 over 95 millimeter per mercury. So based on this table, we can classify Mr. HA on stage 2 moderate hypertension because of his systolic blood pressure within this range 160 over 179, even though his diastolic blood pressure is within this stage 1 reading. Usually we took the highest one, so we can classify Mr. HA as a stage 2 hypertension. So we desired target BP for Mr. HA to make sure that his systolic is less than 140 and his diastolic blood pressure is less than 90 millimeter per mercury. So in this slide, we will talk about the algorithm for the management of hypertension. In addition to the blood pressure reading, we need to assess and figure out how likely that the patient will have a major heart event in the next 10 years, as shown in this middle table. So the patient can be categorized for low, intermediate, medium, high, or very high risk, depending on the blood pressure reading, and at the same time, any co-existing conditions such as the any risk factors, additional risk factors, or target organ damage or targeting organ complications. So let's say if the repeated blood pressure measurement is between 130 and 159 millimeter per mercury for systolic, and at the same time, the diastolic is within the range of 80 to 90 with low or intermediate risk level. So we will recommend the monotherapy with antihypertensive drug. So other than that, consider combination therapy for renal and cardio protections. As mentioned earlier, it is important to initiate the antihypertensive drug to protect organs from damage, especially on the kidney and in the heart. Let's back to our main case study. So we can identify that Mr. HA has one risk factor, which is he is a smoker. Aside his systolic blood pressure within the range of 160 to 179 millimeter per mercury. So based on this table, we can classify Mr. HA as a high risk, or approximately 20 to 30% chances of getting major cardiovascular events within 10 years. So aside we initiate the drug treatment, we also need to counsel him, advise him to stop smoking so that he can reduce the risk from high risk to medium risk of getting cardiovascular events. By initiating the treatments, hopefully he can manage his blood pressure within the treatment goal so that we can reduce the risk to the low risk. Since Mr. HA is a stage 2 hypertension with medium to high risk of getting major cardiovascular events within these 10 years, so we may consider him a combination therapy. So this combination therapy is important to him to prevent, to normalize the pressure, and at the same time to offer cardio and renal protection to him.
Newly diagnosed uncomplicated hypertension and no compelling indications, we should suggest the physician to prescribe either ACE inhibitor, angiotensin receptor blockers, calcium channel blockers, or diuretics. All these four types of drugs have all been shown to reduce the cardiovascular morbidity and mortality. Beta blockers are not recommended as first-line monotherapy, except it should be considered in younger patients, in particular who having the intolerance or contraindication to ACE inhibitor and angiotensin receptor blocker, or women of childbearing potential, as well as patients with evidence of increased sympathetic drive. For those who receive the combination therapy for hypertension treatment, if the target blood pressure is not achievable, we need to increase the dose or change with a drug from another class. The table in this slide shows the condition of the patient and the proof of the effective combinations. For post-stroke or diabetic patients, the effective combination will be the ACE inhibitor and thiazide. For the hypertension patient who having the left ventricular hypertrophy, we should prescribe them with angiotensin receptor blocker together with thiazide diuretics. Meanwhile, for the coronary artery disease due to the hypertension, we can suggest either calcium channel blocker together with ACE inhibitor or beta blocker and thiazide. For very elderly patients, we can suggest ACE inhibitor and thiazide combination. For the medium risk hypertension, Calcium channel blocker is the first line treatment. Combine either thiazide, ARBS inhibitor or beta blocker. For those in the high-risk hypertension, either we prescribe them with the calcium channel blocker with thiazide or calcium channel blocker with the S inhibitor aside of the angiotensin receptor blocker and thiazide. As discussed earlier, this patient, Mr. HA, is a high-risk hypertension. So, the effective combination therapy will be the calcium channel blocker plus thiazide or calcium channel blocker together with the S inhibitor or angiotensin receptor blocker together with thiazide diuretics. Diuretics, often called water pills, are drugs that cause the body to rid itself of excess fluids and sodium through urination. Excess fluid in the body can lead to high blood pressure. The diuretics inhibit the sodium-potassium symporter, which lead to inhibit the reabsorption of sodium ion, potassium ion, calcium and magnesium beside the water itself. Diuretics help to relieve the heart's workload and also decrease the build-up of fluid in the lung and other parts of the body, such as at the ankle and leg. Diuretics can be classified as loop diuretics, which inhibit the electrolyte reabsorption at loop of Henle, thiazide diuretics that can be predominantly found at the distal tubule, and the potassium-sparing diuretics such as antagonist aldosterone that act at the collecting duct. Thiazide diuretics such as hydrochlorothiazide and indapamide is the most common antihypertensive drugs that been prescribed alone or in combination with other antihypertensive agents such as S inhibitor, angiotensin receptor blocker, and calcium channel blocker. Hydrochlorothiazide is effective in the range of 12.5 mg up to 50 mg daily dose. However, please keep in mind, a dose above 25 mg daily is more likely to cause electrolyte and metabolic adverse events. Furosemide is the most common loop diuretic being prescribed globally. Amiloride, spironolactone, and eplerenone are the most common prescribed drugs for the potassium-sparing diuretics. The major side effects of diuretics are hypokalemia, hyponatremia, hypovolemia, and increase the production and increase the excretion of uric acid, or also known as hyperuricemia. Here is the picture of the diuretics drugs that are available in the market. Calcium channel blockers are superior to other antihypertensive agents in Asian population for the treatment of hypertension. The clinical study proved that this calcium channel blocker has high percentage in Asian countries in reducing the cardiovascular death, major cardiovascular events, stroke, congestive heart failure, and coronary revascularization. Calcium channel blocker antagonize the calcium channel at the heart and blood vessel. The main mechanism of action for this drug in the heart by slowing the heart rates through the slowing the sinoatrial node conduction that responsible initiate the heartbeat with electrical impulse. This mechanism able to slow the heart rate, which allows the left ventricle to fill completely and give huge impact in lowering the heart workload. Besides that, calcium channel blocker also able to dilate both afferent and efferent arterial blood vessels. This mechanism leads to vasodilation, which decreases the peripheral resistance, hence lowering the blood pressure. This mechanism subsequently will cause reduction in the glomerular capillary pressure and can prevent from proteinuria. Thus, calcium channel blocker play a major role in prevention of kidney damage and preservation of renal function. The most common prescribed calcium channel blocker as outpatient setting were amlodipine, felodipine, and nifedipine. These three drugs share the same strength as 5 mg once daily, and the recommended maximum daily dose were 10 mg once daily. The combination of calcium channel blocker and RAS blocker such as S inhibitor or angiotensin receptor blocker are superior to other combinations in lowering the cardiovascular events and better safety profile. Let's discuss on the angiotensin converting enzyme inhibitors, or also known as ACE inhibitor. This class of drug inhibit the production of the angiotensin II, which is a potent vasoconstrictor and stimulator of aldosterone secretion. Besides that, an ACE inhibitor also block the degradation of bradykinin and stimulate the synthesis of vasodilating substances including prostaglandin E2 and prostacyclin. Thus, this drug able to lowering the blood pressure by dilating the artery of the blood vessel. ACE inhibitor prove can lowering the cardiovascular risk, reducing the mortality and morbidity in hypertensive, congestive heart failure, post-myocardial infarction patients with reduced left ventricle ejection fraction, and those at high cardiovascular risk. These ACE inhibitors are more effective in preventing coronary artery disease in patients with hypertension. In diabetic patients, ACE inhibitors have been shown to reduce the cardiovascular mortality, prevent the onset of microalbuminuria, reduce the proteinuria, and retard the progression of diabetic and non-diabetic renal disease. The most famous side effect is persistent dry cough due to the accumulation of bradykinin. The most of the ACE inhibitor agents can be dosed once daily for hypertension, except captopril. Captopril usually given 2 to 3 times daily. Please take note, the absorption of captopril can be reduced up to 40% when given with food. Thus, it is our duty to counsel the patient to take captopril at empty stomach. Please bear in mind, patients with renal impairment can deteriorate their renal function. Thus, we need to check their serum creatinine and potassium level before the initiation of ACE inhibitor. Besides that, we also need to check back the serum creatinine level and potassium level within the 2 weeks after starting this drug. If there is hyperkalemia, which more than 5.6 millimole per liter, or persistent rise of serum creatinine level more than 30% from baseline within these 2 months, the dose of the ACE inhibitor should be reduced or we should discontinue this drug. Please keep in mind these ACE inhibitors are contraindicated for pregnancy and breastfeeding women as may increase the fetal and neonatal mortality. Angiotensin II receptor blocker, or also known as ARB, are the drugs that most often prescribed for people who experience side effects with ACE inhibitor. ARB are used to treat high blood pressure and heart failure. Rather than lowering level of angiotensin II, which as ACE inhibitor do, angiotensin II receptor blocker prevent this chemical, which is angiotensin II, from having any effect on the heart and blood vessel. Thus, the blood vessels are relaxed, which increase the supply of blood and oxygen to the heart muscle. ARB are preferable for ACE inhibitor intolerant patients that developing the dry cough. Unlike ACE inhibitor that can cause persistent dry cough, as discussed previously, ARB do not cause the dry cough. ARB are effective in preventing progression of diabetic nephropathy. Besides, it's also proved to reduce the incidence of major cardiac event in patients with heart failure, hypertensive, left ventricular hypertrophy, and diastolic heart failure. However, this cardioprotective effect of ARB for prevention of myocardial infarction were recently called into question. Large meta-analyses conducted by many researchers showed that ARB, although did not increase the risk of myocardial infarction, it seemed not to have special cardioprotective effect unlike the ACE inhibitor. Despite conflicting findings from various meta-analyses, it is important to look at the original study. First, in high-risk cardiovascular patients with or without the hypertension, ARB are not inferior to ACE inhibitor for cardiovascular protection. Second, in patients with left ventricular dysfunction, ACE inhibitors have more evidence including reducing the mortality, and ARB is used for ACE inhibitor intolerant patients. For diabetic patients with or without hypertension, and for non-diabetic nephropathy, type 1 diabetic mellitus with nephropathy, ACE inhibitor improve the cardiovascular outcomes including the total mortality, especially in combination with thiazide diuretics. In type 2 diabetic nephropathy, both ACE inhibitor and ARB improve the renal outcome, but only ACE inhibitor has the added advantage which improving both cardiovascular and renal outcomes. Although beta blocker is not indicated as first-line treatment for the treatment of hypertension, it is useful in hypertension patients with effort angina, tachyarrhythmia, or previously myocardial infarction, where they have been shown to reduce the cardiovascular morbidity and mortality. Certain beta blockers have been shown to be beneficial in patients with heart failure. However, it is contraindicated in patients with uncontrolled asthma and any other forms of obstructive airway disease. Atenolol, betasolol, bisoprolol, and metoprolol are the four drugs that has the cardioselective at low dose, which are bind more avidly to beta-1 receptor compared to the beta-2 receptor. Thus, these four drugs are less likely to provoke the bronchospasm and cause any vasoconstriction. Thus, these four drugs are safer in patients with asthma, COPD, diabetic mellitus, and peripheral artery disease. Please keep in mind, do not abrupt cessation of beta blocker therapy, which the abrupt cessation may produce the unstable angina, myocardial infarction, or even death in patients predisposed to ischemic myocardial events. For this reason, it is always important to taper the dose gradually over 1 to 2 weeks before discontinuation. Let's back to our case study discussion. In our last discussion, we have decided that Mr. HA should receive combination therapy, which either calcium channel blocker with thiazide or calcium channel blocker with ACE inhibitor or combination of angiotensin receptor blocker with the thiazide diuretics. As our last discussion, we have known that ACE inhibitor combined with dihydropyridine calcium channel blocker such as amlodipine, felodipine, nifedipine is more preferred over the combination of ACE inhibitor and thiazide diuretic in patients with hypertension and has high cardiovascular risk. We recommended Mr. HA to receive the perindopril arginine 5 mg plus amlodipine 5 mg that available in one single pill. as shown in the picture here. Most of the well-controlled hypertension patients request to stop taking their medication. Do we allow that? Yes, if this patient has following criteria, which the blood pressure must not be higher than stage 1 or mild hypertension with low cardiovascular risk. He also needs to at least has 1 year well-controlled blood pressure on the same medication at the same dose. He needs to agree to be followed up at least 3 to 6 monthly and need to be motivated to adapt the healthy living style.